In this video, I'll talk about how to approach a case of confusion in the long clinical consultation of the MRCP PACES exam. This symptom has been requested by one of our viewers, so if you're experiencing any difficulty with any particular case or a symptom, you can leave a comment down below and I can cover that in the next video. Coming to confusion, although this is an uncommon case, this still needs to be well practiced. So confusion is a case where you'll be taking history from a surrogate as opposed to a patient. Although in international centers, you're mostly asked to take history from a surrogate as opposed to talking directly with the patient. This doesn't happen in the UK centers where you'll be talking directly to the patient. This is one of those cases where the patient, depending upon their current state of mind, might not be the best narrator or reliable narrator or a historian. So you're always asked to talk to a witness or a family member, next of kin. So you'll be talking to a surrogate. Before talking about the exact history questions that you need to ask, we'll talk about the thought process that needs to be changed while while you have the 5 minutes before you enter the station. So you'll be given some information, that is the patient's name, age, the presenting complaint, which is confusion in this case. This is the bare minimum that is given. You might be given some additional information, for example, vital signs, and in some cases, some investigation results as well. So you need to take all that into consideration, that is whether the patient is male, female, young, middle-aged or an elderly, because the cause of confusion will differ from a young patient as opposed to an elderly person, and we'll talk about that in detail now. To cover a wide array of differentials, there's a mnemonic called vitamins. I've talked about this before in other cases as well. Vitamins stands for vascular, infectious, trauma, autoimmune conditions, metabolic conditions, inflammatory, neoplastic, and psychological conditions. So you can apply it on any symptom. This helps you in your realistic or real bedside clinical practice as well. So let's talk about confusion and vitamins. So V, which is vascular causes. If you think about vascular causes of confusion, you can think about maybe vascular dementia or a stroke for that matter. Infectious causes could be meningitis, encephalitis, meningoencephalitis, or any other CNS or neurological infections. Trauma can cause traumatic encephalopathy. For autoimmune conditions, you can think about neurological complications of autoimmune conditions. So it could be lupus cerebritis in case of SLE or neurosarcoidosis. It can be a malignancy or a psychological cause of confusion. So we'll talk to the patient and try to narrow down our differentials by ruling each one of these categories out. Depending upon what system is involved, you can also classify it based on drug-related causes, so alcohol, opioids, benzodiazepines. It can be endocrinological in nature, for example, having diabetes resulting in confusion. It could be related to DKA or hypoglycemia or hypothyroidism. Coming to the exact history taking now. It should be started with an open-ended question. So what do you mean by confusion? Can you explain a bit more about it? And then you narrow it down to specific questions. You can apply the mnemonic ODPARA, which covers non-pain symptoms. So in this case, asking about the onset. Another open-ended question or an opening question that you can ask is, has this ever happened before? This can be asked in any symptom and any case, because you're trying to establish whether this is the first episode, especially in context of neurological symptoms, keeping multiple sclerosis in mind, which is spread over different time periods. So you can figure out whether this has happened before or not. So symptoms spaced over different time periods can prompt you towards thinking of multiple sclerosis as a potential cause, especially in neurological symptoms. Okay, is this the first episode? Has this ever happened before? Was it all of a sudden? Whenever any symptom is sudden, you can ask about an open-ended question again. What were you doing at that time? The patient can give you a history or narrate as to what was happening, and you can pick and choose what is relevant to your case. So, for example, if it's a case of seizures, back pain, confusion, ask them what were they doing at that time. Next question is about, is it episodic? Is it coming and going? Was it only just one episode? Is it getting more frequent with time? Is there any particular time of the day when it's happening? This gives you more context if you have just a singular episode versus something that has been happening frequently. Moving on, you can then ask about any behavioral changes. This includes the patient acting strangely, so personality changes, being more aggressive, irritable, agitated, maybe low mood or depressed. This gives you an idea of about any personality changes. You can expect this in some cases of frontotemporal dementia. So, although this is not a case that is very common in the PACES exam, but we're talking about your daily practice as well. So, taking a good history can reveal a lot. So, this is one of the questions that you need to ask in the case of confusion, followed by memory problems. So, if they do have memory problems, you need to then differentiate whether it's with recent memory or recalling past events. You then need to cover hallucinations, that is all auditory, visual, tactile, olfactory. So have you been seeing anything that is unusual or strange, hearing unusual voices, smelling anything unusual? um, this covers the hallucinations. You can expect some hallucinations in Lewy body dementia. Do you have any trouble with concentration? This is a good question to ask. If it's a young patient, you can ask them if they have any difficulties, learning difficulties, or difficulties with performance at school or recreational activities. If it's a middle aged or an older patient, you can ask about if they're having any difficulty in performing their daily tasks. You can then come to the CNS systemic review. Given that it's a primarily neurological symptom, you should start with, do you have any headaches, any vision problems, moving on to any weakness in any part of the face or body, any dizziness, fits, loss of consciousness, problem with your walking or balance. And then an important question would be, do you have any swallowing difficulty or speech difficulty? This is important, especially swallowing difficulty, given that this is a red flag. If there is swallowing difficulty present, then you would have to admit the patient and get a SALT assessment done, so which is the speech and language assessment team. This gives you more of an edge to secure welfare points and judgment points because you're modifying your treatment and investigation plan based on this question. After this, you can ask about any numbness or tingling in any part of the body as well. This covers your CNS review. Before moving on to other systems, you need to ask about the past medical history. This would be the right time because this gives you a lot of context as to what the major underlying cause of the presenting complaint could be. For example, the patient gives you history of diabetes. This gives you a lot of context. The patient might be experiencing DKA, they might be having hypoglycemia at that time, so you can ask some follow-up questions regarding their medications and did they check their blood sugar at that time. A detailed medication review is also needed. That includes the current medications, which is the prescription. So please can you show me your prescription? Followed by over-the-counter medications, any herbal medications, any medications that were stopped recently. This is really important to explore because there are a lot of drugs that can cause confusion, like we've talked about in the previous slides, that it can be benzodiazepines, opioids, it can be insulin or oral hypoglycemics, specifically sulfonylurea, especially in older patients, that can cause hypoglycemia. So explore that really well. You can ask about the family history next, maybe some kind of neurological conditions running in the family, and then personal history. This is again really important. This covers smoking, drugs, and alcohol. Alcohol being one of the most important causes, so it can be binging alcohol or excessive alcohol intake, alcohol withdrawal. Both of these conditions can result in confusion eventually. The recreational drugs is also an important question. Always give a disclaimer to the patient that you're going to be asking some personal questions and then ask about their recreational drug history. We then move on to the red flags. I've done a whole video on red flags and how important it is to evaluate this and how it gives you a lot of edge again in clinical judgment, securing welfare points, deciding whether the patient needs to be admitted, how urgent a review needs to be done. So asking about fever, asking about any weight changes. So you need to ask, because fever is sometimes considered a jargon, ask for any raised body temperature. Ask about weight changes, so it covers both weight loss and weight gain. And if there's weight loss, you got your red flag symptom here. asking about lumps or bumps in the body to cover lymphadenopathy, and then you can ask about night sweats as well. Once you've done with this, you can then quickly cover the review of systems, which is a quick head-to-toe assessment. You can ask about any palpitations, breathlessness, chest pain, changes in the bowel habits, problem with the waterworks, coughing. So this covers the rest of the systems. You can ask about any joint pains, fatigue, any problem with sleeping or sleeping difficulties, any problem with the mood. This is the bare minimum that is required. You can ask that in a really quick succession. You need to ask about what the patient does for a living and how is it impacting his life and his job, and offer support where needed. Driving needs to be assessed. So at this point, if you're not sure of what the diagnosis is, you can let them know that it's not safe for them to continue driving. You need to stop driving temporarily. This is a time dependent decision because you need to examine the patient first till you get to a diagnosis, and if you're still unsure by the end of the consultation, then it's still fine. You can let them know that you want to run some tests first before you let them know that it's okay for them to drive. So this is for welfare points. Before moving on to the examination, this is a reminder that if you're having any difficulty in preparing your long cases and communication cases, if you don't have any study partner, you can send me a DM on my Instagram, PACES Guide, or leave a comment down below. Contact me. I offer one-on-one coaching sessions. These are exam oriented, followed by an RCP feedback. You can also contact me for the ebook. It has covered a lot of scenarios that you might experience in your daily life, cases such as angry patients, breaking bad news, medical errors, DNR decisions, how to talk to a patient in layman terminology. So a lot of things are covered. If you want more information, just send me a DM or leave a comment down below. Okay, moving on to the examination now. You need to start with the observation chart. This either would be given already, or you need to ask the examiners. So I'd like to know the vitals. Check the vitals and then move on. You need to do a quick assessment of the patient's current mental state, so a mini mental state examination. Let the examiners know that you want to talk to the patient, especially in international centers. When you're talking to a surrogate, you're not allowed to take history from the patient. So apart from giving commands in assessing the mini mental state, you have to ask questions about maybe their age, where they are, etc. So you need to have the examiner's permission to go ahead. So if they want you to do so, they'll ask you to proceed. You can quickly ask them questions about their name, age, where they are right now, if they know whether it's day or night, what time it is, what season it is, what year it is. You can ask them questions to check their orientation. You can ask them to name any object that's in your hand, and then move on to the detailed examination. You'll be expected to do a neurological examination, but it should be very focused. You can check the pupils, do the H-chip movement of the eyes to check for the cranial nerves. You can check for the pronator drift, maybe the facial nerve or the fifth cranial nerve. Now, this point onwards, everything will be curated according to the history that you've found. It could be maybe an endocrinological cause or a neurological cause. Depending upon that, you'll have to carry out the rest of the examination, which will be very focused. So the bare minimum that is required in every case is the observation chart, the general physical examination, a quick mini mental state examination after the examiner's permission, offering a fundoscopy, and then doing the relevant exam. Coming on to the investigations now. Now, based on the examination, you will have then 2 minutes to talk to the surrogate or the patient. They would have some concerns. You can address those based on what you found in the history and examination. Let's say you're not sure, you can still let them know what your plan is. That is, if you want to admit them, whether you want to do an imaging, whether you want to run some tests, just let them know what you're thinking of. If you have 2 or 3 diagnoses in mind, then you can let them know about the topmost differential that you're thinking of and base your responses on that. After the viva starts, you'll be asked about your differentials and how you would investigate and manage. This is how usually the viva goes. So in case of investigations, you need to start off with maybe a full blood count. There's urea, electrolytes, liver renal function test. There's urinalysis, a metabolic profile. You will need to see calcium, magnesium. Whether brain imaging needs to be done is based on what you found in the history and examination. Now, these are a list of tests that can be done, but they should be very specific. based on your case. There should not be a memorized list of investigation. It should be memorized. It should be very focused and modified based on your case.